Good evening, Carbon County. Thank you for joining us for this month's provider workshop. Tonight we have Dr. John Lumb, General Surgeon for Memorial Hospital of Carbon County. Dr. Lumb will be speaking about colon cancer this evening, and after the presentation we'll be addressing any questions the audience may have. With that, we'll turn it over to you, Dr. Lumb.
Hi, good evening. Well, when Stephanie first talked to me about whether I'd want to present something on Facebook Live, I said sure, and then we talked a little bit about what we might want to present. And I thought colon cancer would be a good topic for Rollins because we do a lot of colon cancer screenings, and I think it would be of some benefit to have the population here know a bit more about it. So who am I, and what makes me an expert? So I was born in Canada, as you see. I grew up in Houston. My parents didn't like the snow in Canada, and I grew up in Houston from age 4. I I did my undergraduate at University of Texas, and I got an engineering degree, but decided I wanted to go to medical school. And I went to medical school in Houston, then decided I was going to do a residency program at a community hospital, which I found in Pontiac, Michigan. After I left Pontiac and graduated residency, I practiced surgery in Arkansas for 5 years. And then I went to Tennessee and lived there for 20 years. And now I've been in Wyoming for 3 years. So why did we come to Wyoming? Well, we love the West, and that's my wife. And we love hiking, we love the mountains, and we just like living out here. So March is Colon Cancer Awareness Month, so the timing is good for this talk. I chose this slide because colon cancer is one of those diseases that sometimes you don't see everything on the surface. Sometimes things are lurking beneath, and we need to be aware of that. So let's talk about the anatomy of the colon. The colon and large intestine are the same thing, and it has various parts. The ascending colon, which is where the small intestine comes into the colon, the ascending, transverse, descending colon, splenic flexure, and then down to the rectum. And all those parts can end up developing cancer. So one of the important points of the talk really is that cancer progresses. Almost all cancers arise from polyps. Polyps are benign when they're polyps, but if allowed to grow, they turn to a malignancy. And again, they can occur anywhere in the colon, and they'll start small as just an irregular growth of cell tissue, and as they start to multiply, they'll become more aggressive and start to erode through the intestinal wall, start to involve lymph nodes, and once it gets large, there's potential for it to enter the bloodstream and go to the liver and the lungs. We don't want that. So colon cancer statistics. Every year in the United States, there's 104,000 new cases of colon cancer, and approximately 45,000 in the rectum. The lifetime risk of people, men, 1 in 23 will develop colon cancer, and in women, 1 in 25. And in the United States, there's about 50,000 deaths per year from colon cancer. Now that trend is decreasing, and it's thought that the reason it's decreasing is because of colon cancer screenings, such as colonoscopies. So what you can see under the trends here is the overall deaths are decreasing in people over age 55. But unfortunately, colon cancer is being diagnosed more and more in younger people, and the deaths are increasing at a pretty significant rate in young people. And that includes 25-year-olds. And I don't know if people are aware of the news, obviously. Chadwick Boseman, who's a a movie star, died at a young age from colon cancer. He was a star in Black Panther. So, what are the risk factors of cancer? Older ages, even though it's becoming less common in older ages, older age is still a risk factor, and it's still much more likely as an older person to develop colon cancer. African Americans tend to develop colon cancer at a more frequent rate. If you've had a previous history of polyps or you've had a previous colon cancer resected, you're much more likely to get another colon cancer at a later date. If you have inflammatory bowel diseases like ulcerative colitis or Crohn's disease, that puts you at higher risk. And then there's genetic syndromes. Lynch syndrome, which is a syndrome that makes it more common to develop colon, but also breast, uterine, ovarian, other types of cancers like that. And then familial polyposis, which is as it states, runs in families, but oftentimes people at the age of 20 will develop thousands of polyps, and if left alone will have almost 100% risk of developing colon cancer. And then even if you don't have a genetic syndrome, but you've got a close family member that has a family history, then you're much more likely to have colon cancer. So the need for screening is high in those situations. So other things to consider: if you eat a high-fat diet and you don't take much fiber, that puts you at higher risk. Sedentary lifestyle, diabetes puts you at a slightly higher risk. Obesity, smoking, heavy alcohol use, and if you've had radiation therapy for other conditions, such as uterine cancer, the exposure of the radiation to the colon increases your risk of developing colon cancer. So is there anything you can do to reduce your risk? Well, yes, you can eat a variety of fruits and vegetables and grains, high fiber diet. You can drink less alcohol. You can stop smoking. You can exercise more. And you can maintain a healthy weight. But keeping that in mind, many people that I see that have colon cancer have zero risk factors. So you can do everything right, and you can still have colon cancer. So being seemingly healthy with no family history and no symptoms does not guarantee you are cancer-free. I have people coming to the office all the time, they're 60, they've never been screened, and they say, well, I don't have a family member that's ever had colon cancer. That does not mean that you're not going to get it. Most of the people that come in that have colon cancer don't have family cancer in their family. So, and then once that symptoms start to develop, treatment and cure become more difficult. So the key is you want to be seen and screened and catch things early before symptoms develop. So what are the symptoms? Like I want to stress, most people developing colon cancer have no symptoms at the start. That's when you want to catch it. But if you're starting to have any of these other symptoms, that's certainly a reason to be checked more urgently. And what we're talking about is a change in bowel habits or change in consistency. And that's like, oh, I used to go to the bathroom, once every day, but now I go every 3 days. Or now I've suddenly had a lot of diarrhea and I go to the bathroom much more frequently than I used to. And if it just happens for a week, it doesn't really count. If it happens for a month, I would say you definitely need to be checked out. So rectal bleeding, and that's a big one because a lot of people just assume anytime you pass any blood that is probably hemorrhoidal. And most of the time it is, but even doctors make this mistake and they say, oh, you're too young to have colon cancer. that's just got to be hemorrhoids causing the bleeding. Well, you need to be your own best advocate, and if you're bleeding, it needs to be checked. And you know, I think the youngest person I've found colon cancer in is a 25-year-old, and it was late stage, and there was really not much to be done. So do not just assume. Once you get your colonoscopy and test and know that everything's okay, then you treat the hemorrhoids. Don't just assume. So also, if you're having persistent abdominal pains, crampy in nature, that needs to be investigated. If you have that feeling after a bowel movement that you just didn't quite empty. If you've developed this chronic fatigue and tiredness, it's worth looking into. Obviously, there's several things that can cause that, but colon cancer is one of them. I think basic blood work can oftentimes detect some problems. Oftentimes, if you do basic blood work and you've got an aggressive colon cancer, you'll be anemic on your blood work. And then if you have unexplained weight loss, obviously that also can be a number of things, but colon cancer is a consideration and maybe a reason to get investigated. So what types of screenings are there? Well, most people would still say colonoscopy is the gold standard. And the reason is not only is it diagnostic, you can find polyps, you can find problems, but you can also take care of it at the same time. So you happen to do a colonoscopy, you see a polyp, and you can just remove it while you're there. But in addition, other types of screening tests are the Hemocult test, which is basically, it's a little card test that they do. They check your stool just to see if there's traces of blood in it. It's fairly sensitive for detecting a problem, but it'll detect blood in your GI tract that might just be from a bleeding tooth or a stomach ulcer or all kinds of things. And then there's a newer test that's out there that you probably have seen ads on TV, the Cologuard test, which is a DNA-based screening where they send you a box and you get a sample and you send that in and they tell the result. And what happens is they will tell you it's either positive or negative. If it's positive, then you need to proceed and get a colonoscopy at that point. At that point, it's not considered a screening, it's a diagnostic to see what actually is causing your DNA for this to come up positive. So if you're wanting to get away from doing colonoscopies, oh, you know, it sounds disgusting and it's, you know, I don't want to do it. This is better than nothing, but there's a lot of false positives and false negatives. I wouldn't say a lot, but it's probably 92% sensitive, and that means that it'll miss 8% of colon cancers. So colonoscopies aren't perfect either, but I would say they were better, and I think a more reliable test. When the Cologuard first came out, in fact, I was seeing a lot of patients being sent to me because they were positive, and then we did the colonoscopy and didn't see anything. So there were a lot of false positives initially, but lately, in people that I've been referred positive Cologuards, we've actually seen pretty significant polyps and things. Okay, so the various stages of colon cancer. This is stage 0, really, where it's just at its outset. It hasn't really started penetrating through the colon wall. Stage 0 really isn't considered a cancer at that point. Stage 1 is where it is just confined to the inner lining of the wall. Stage 2, it's kind of going through the wall, but no lymph nodes are positive yet. And then stage 3, lymph nodes are positive, and then stage 4 is at the end stage where you're getting metastasis to liver and lungs and that sort of thing. We do not want to get here. So, this is a basic garden variety colon cancer, and this is not in the, I mean, this is a later stage, but not the latest stage. I mean, as it grows, it actually will go completely around and then start obstructing the colon. And so, but this is a pretty garden variety appearance. And then, so the treatment of the cancer is dependent on staging and the location in the colon. But again, emphasis on early diagnosis, and then rectal cancer treatment is somewhat different than cancers found in the rest of the colon. So again, the diagnosis is initially made by the colonoscopy, and then you take tissue samples and biopsies during the colonoscopy. And once you have the pathologic diagnosis, then usually you'll do a staging CT scan to help determine the size of the tumor, whether there's involvement of the liver. It sometimes we'll see enlarged lymph nodes. And then we start making plans for surgery. And then surgical resection is the mainstay, is the most important aspect and hope for cure of earlier stages of cancer. So in stages 1, 2, and 3, even when there's lymph nodes involved, it's still considered surgery as a primary treatment. If there is lymph nodes involved, then usually you will offer chemotherapy postoperatively to hope to try to contain any small cells that may have gotten out of your surgical resection. So I just thought I'd mention rectal cancer treatment, or treatment of the rectum instead of the rest of the colon here. Once you get down into the rectum, you're confined in a much tighter space. And so you got bony prominences, you've got muscle tissue, and this muscle helps you control your bowel movements, the sphincter muscles. And if the tumor is invading that, it becomes a much more complex issue, because if you just go and say, okay, we're going to surgically remove all that, then that's pretty much leaving the patient with a permanent colostomy, which most patients do not want. And so if sometimes the tumor is in this area, you can give them chemotherapy and radiation preoperatively, and that will shrink the tumor and hopefully get it away from these sphincter muscles, where it can then be resected and hooked back together and spare rectal function. So what can we do here at home? This is our hospital. This is my employer, where I've been happy for 3 years. And what can we do here? Well, first of all, we have a lab department. We've got x-rays, including CT scans, MRIs, all the things you need to evaluate staging for colon cancer. We have the ability to do screening colonoscopies, which we do quite a few of. And then once we define something, we are capable, and very capable, I think, of doing surgery for colon resections and reconnection of the, you remove a segment, you hook things back up. And this is our crew. They're going to kill me for posting this slide. There's been a few changes in the operating room, but I think that, you know, in reading Rollins News and Chatter, you know, people are talking about the hospital and this and that, but in my experience and my being around several hospitals throughout the country, I think our hospital does a pretty good job. And I think the care that you get here is from people that are like family. They're local. They live here. They're invested in this community. So they care about you, and they want you to do well. And these are the smiling faces you may run into whenever you come into the hospital. So what is the take-home message? What do you take home from this talk? Well, colon cancer is deadly. And the second most important thing, almost all colon cancer deaths can be prevented. And that's what I really want to ring true is if you come in and get screened, you're preventing colon cancer from forming. If we're removing polyps, we could be preventing a colon cancer. And so that saves lives, and it's been proven. And that's why colon cancer deaths throughout the country are going down. We can do it very easily here in town. There's no reason for you to be driving up to Casper and spending a night in Casper doing a colon prep and driving home the next day with, under anesthesia and all that. I mean, I just think it's something very easy to be done here. And most treatments of the early cancer can be done here. So surgery can be done here. Usually if you have a surgical resection, it would require a few days in the hospital, 3 or 4 generally, depending on overall health conditions. And then, I will say that there are certain cancers that we will not even attempt to do here. I understand this is a small hospital and we're a long way from help if we run into trouble. So it's a matter of trust between patient and doctor. We are not going to get in over our heads, and if it's a rectal cancer, for instance, and you need radiation and you need chemotherapy first, that's not something we offer here. But in the run-of-the-mill, the general colon cancers, those are very easily done here. And so another change that has come in the last few years is the American Cancer Society has actually recommended colon cancer screenings to be started at age 45. And that's because of what we said before. Colon cancer deaths are going up in young people. And we don't really know why that is, but that's just a trend in the statistics. And so the Cancer Society has recommended that. All insurances have not quite gotten on board to pay for it yet, so we're still kind of pushing for that, but just something to think about. Also, if you have a family member who had colon cancer at the age of 30, and so you're not going to wait till 45. Generally, if you have a family member, a close family member, a sister, and she had colon cancer diagnosed at age 30, you probably want to start colonoscopies at age 20, 10 years before the diagnosis of your relative. So we can enjoy life. That's the end of the talk.
All right, thank you, Dr. Lumb. So we do have a few questions. Earlier in the presentation, you spoke about Wyoming. So going into that in a little more depth, how does Wyoming compare to other states in terms of colorectal screening numbers? And in addition to that, how does the occurrence vary state by state? Do you see higher trends based on demographics in certain regions of the country?
I haven't really researched that much. I would say, in my experience, is that, well, first of all, Wyomingites don't like to go to the physician as a rule. And, they're independent people, they're independent thinkers, and so, there are a lot of people I see coming to me after the age of 60 for their first colonoscopy, which is unusual. Most people where I came from in Tennessee, colon cancer screenings would generally start at the age of 50, and most of the people will get it at younger ages. So now, also, I would say Western people tend to be a little more fit, a little as far as more active lifestyles, and so I have not seen a significant bump or increase in colon cancer diagnoses since I've been out here. But again, statistically, I don't know on the paper really what that is.
Thank you. So you spoke about polyps and that this often stems or begins as a polyp. Are there different types of polyps and how do those differences correlate to an increased risk of colorectal cancer?
Yeah, we'll see often doing the colonoscopy, a lot of polyps you can tell by looking at them that they are hyperplastic and have minimal risk. We still often remove them just to make sure that the biopsy kind of coincides with what our visual inspection looks like. But there is a scale of different types of polyps, of adenomatous polyps, and those are precancerous polyps, from tubular adenomas to what's called villous adenomas. Tubular have maybe a 5% chance over the course of several years to turn to cancer, where a villous adenoma has over a 50% chance of turning to cancer. So, and oftentimes you can tell by looking at them during the colonoscopy what type of polyp you're looking at. But we send all of them off to be looked at by the pathologist.
So for those that have been diagnosed with cancer, what does post-treatment look like for those individuals?
Well, okay, so we didn't talk too much about it, but the earlier stages that are resected and are, oftentimes you don't know the absolute staging until you remove a segment of colon, including lymph nodes. You send that to the pathologist, and once the pathologist looks at it under the microscope, they could tell if there's any tumor involvement in the lymph nodes. If there's no involvement of lymph nodes and the tumor is not penetrating into other organs and other things, usually surgery is the end of treatment, other than screenings down the road or repeat colonoscopies to further inspect and make sure that no other polyps or tumors are arising. If there is involvement of lymph nodes, or if it looks to be an aggressive tumor, then we will get an oncologic consult. We'll have to send you to a specialist, and they will kind of assess to see if you may be a candidate for chemotherapy.
Thank you. So how would someone go about making an appointment to see you and begin this process?
It's just a matter of calling the office.
And you are located, for everyone's information, Dr. Lumb is located at the MHCC General Surgery Clinic, which is on the second floor of the hospital, and can be contacted by calling 324-6022. So at this point, it does not look like we've had any other questions come in. As always with our provider workshops, for the viewers, if you think of something after the fact, you are welcome to send those questions through us via Facebook, and we will direct those questions to Dr. Lumb to answer those questions. And with that, we'll go ahead and wrap things up this evening. Thank you very much, Dr. Lumb,
All right, you're welcome. Thank you very much.
Carbon County Higher Education for hosting us this evening.